Thank you, Tarun. I am not exactly sure why I was given this topic. It seems rather out of place for a interventional coronary intervention meeting, and so if half the audience leaves now, I won't be surprised. But if those of you who have an interest in where this field stands today, I will give you an overview of carotid artery stenting. So we all know that stroke is a leading cause of morbidity and mortality, and of carotid artery occlusive disease accounts for 20 to 30% of strokes. And it has been established long ago that endarterectomy is superior to medical management both in symptomatic patients and in asymptomatic patients with atherosclerotic carotid bifurcation disease. So this atherosclerosis that causes stroke is predominantly at the carotid bifurcation. So the NASET and ACS studies demonstrated that doing endarterectomy is superior to medical management as it was practiced at that time. We are looking like 40 or 30 years ago. So endarterectomy was started in 53 by Michael DeBakey, and basically they core out the atheroma that's located in the carotid bifurcation. But this is an invasive procedure. Invasive meaning it's surgical, and there's a scar and morbidity and all that. So people have been looking at percutaneous methods of dealing with this, and the first percutaneous carotid angioplasty was done by Klaus Matthias in 81, and then he's also the first to have done carotid artery stenting in 1989. And in India, we jumped onto the bandwagon in 1996, and this is the first publication on carotid stenting in India, which came out in 96 in the Indian Heart Journal. Since then, there have been numerous studies looking at both endarterectomy and carotid artery stenting. And you can see that over the last 50 years for surgery, that's the top set of bars, and more than 20 years of carotid stenting, that is the bottom set of bars, the death rates and 30-day stroke rates have been steadily falling for both the techniques. And now both the techniques are actually excellent. And we are now in like 1.7% for endarterectomy and 1% for stenting. So techniques have improved on both fronts. And all along we've been comparing these two. But this is the one study that I will put out for you. It came out in 2010. It's the KRISH study, which compared surgery, endarterectomy with carotid stenting. And there were 2,500 patients with both symptomatic and asymptomatic carotid artery stenting, stenosis. They were randomized to either endarterectomy or stenting. And the primary composite endpoint was stroke, myocardial infarction, and death from any cause during the periprocedural period. And then they also looked at stroke 4 years down the line on the side of the lesion, ipsilateral. And they had a follow-up of 2.5 years. So if you look at the composite endpoint, it was pretty much the same all the way out to 4 years. Not much difference between the two techniques. But if you broke it up into death, stroke, and MI, death was the same. Stroke was significantly more for carotid artery stenting, 4.1 versus 2.3%, highly significant. Whereas MI was more in the surgical group, 1.1 versus 2.3. And the ipsilateral stroke at follow-up was the same in the two groups. So if when you do a quality of life survey on patients who've had endarterectomy and stenting, they tend to take stroke as terrible. It really affects quality of life. But if you have had a small MI, it doesn't really change your lifestyle very much, because most of these MIs were small MIs. So this kind of result was replicated again and again and again. Every study you compare the two, you find the stroke rate is higher with stenting. And the CRISH strokes, of course, they were mostly minor, mostly ischemic, mostly anterior circulation, and mostly ipsilateral. But they were associated with significant morbidity and nearly threefold increased future mortality in these patients. So, care of all the CRISH trial and many other trials, these are the current guidelines. Of course, there are many guidelines. I won't take you through all of them. I'll just take the one that came out last year, the ESC guidelines. And if you look at symptomatic carotid stenosis, endarterectomy gets a class 1A indication if the stenosis is 70 to 99%. And if it is 50 to 69%, again endarterectomy gets the priority. It now becomes a 2A indication, not a 1 indication. So when will you do carotid stenting? So the only indication that is 2A for carotid stenting is if the surgical risk is high and you have a 70 to 99% stenosis, then you can do stenting, and that also it's only a 2A. It's not even a class 1. So this is pretty depressing for us cardiologists and interventionists, that even after 20, 30 years of a lot of work, this hasn't beaten surgery, and surgery is considered the treatment of choice. And if you were to do stenting, you should restrict yourself to the younger age group, that is below 70, because above 70 the risks go up. And then it becomes actually a 2B. So it is not even agreed by everybody that you should do it. What about, so I was saying this high risk for surgery, it can be clinical or anatomic. Anatomic is like if there's been a neck radiation or the various other things that are listed here. So if these are there, then only you will think of doing a carotid stenting. So what about asymptomatic carotid artery stenosis? Now here, currently with very good medical therapy, they say that if the patient is asymptomatic and there are his life expectancy is short, or he doesn't have what are called high risk features. I will explain what is high risk feature for carotid lesion. If those are not there, then just leave him alone. Just manage him medically. Don't do any kind of intervention. So when will you do intervention for asymptomatic carotid stenosis? So if the surgical risk is average, then and there are these high risk features, then you will do endarterectomy. And if in the same group, if you were to consider stenting, it's only a 2B indication. So again, endarterectomy gets the priority. And if the surgical risk is high, and of course in that case you will want to do carotid stenting, they still give only a 2B indication. So both for symptomatic and for asymptomatic, stenting has been kind of relegated to second place as compared to endarterectomy. So these are the high risk features which should be there in case you're planning intervention for asymptomatic lesions. So that it could be imaging features or clinical features, and it's something like vulnerable plaque in the coronaries. So if you have large plaques, echolucent plaques, hypoechogenic area, then you will say that this is a high risk lesion, and you will think of an intervention. Now, stenting has some conditions which you should try and avoid doing stenting, both clinical and anatomic. I mentioned that elderly patients do badly with stenting, and anatomically, if there's a high grade arch atheroma or a very curved arch like type 2 or type 3 arch, then on all these conditions that are listed here, these are not suitable patients for doing stenting. So there are high risk features for surgery, for stenting, and the lesion itself. So, people have been looking at why is this stenting always having a slightly higher risk of stroke. That's because you've got to reach that lesion in the carotid bifurcation. So you have to go through the arch, and if there is atheroma in the arch, you may dislodge that. And then you have to cross the lesion in the bifurcation. And even if you want to put an embolic protection device, if it's a filter, you have to first cross the lesion, then only you can put the filter. So both of these are essentially unprotected, going through the arch and crossing the lesion to put a filter. Of course, now we have a different kind of protection device, which is a proximal occlusion device, which doesn't need to cross the lesion before uh, crossing the lesion. And also, when you balloon the lesion, put the stent, and do a post dilatation, then again you can set off particles, and these particles can be quite tiny. So the filter that we put, it only stops particles more than 100 microns. So they found that 60 to 80% of particles are actually less than 100 microns. So they do get through, even with a filter. So that is why we have more stroke with carotid artery stenting. So people have been now looking at another technique. This is called transcarotid artery revascularization, where you directly enter the carotid artery. So then you don't have to go through the arch. You are directly entering the common carotid artery. So this is called TCAR. So it is a hybrid procedure. That means a bit of it is surgical and the rest of it is endovascular. So you need to make an incision in the lower part of the neck between the two heads of the sternocleidomastoid, where the common carotid is located. And then you put in a very short sheath, and that sheath just goes in like 2 centimeters into the artery. And then surgically they put a loop and they close off the proximal carotid artery, so the flow stops, and then they draw blood out of the common carotid and feed it back through the femoral vein. So they are reversing the flow in the common carotid artery. And after that, they cross the lesion with a wire and put a stent. So this has avoided the two risks that I mentioned in the slide before. That is the risk of embolization when you go through the arch and the risk of embolization when you cross the lesion. So this has done pretty well. Of course, you can't do this if the internal carotid is very small or the common carotid is very small or very short. But it has done pretty well. So if you compare this TCAR with stenting, the stroke rate is significantly less. And if you compare TCAR with endarterectomy, the stroke rate is almost the same. So now you've got the lower stroke rate of endarterectomy without having to do a completely open surgical procedure. So has this made it into the guidelines? The only mention is in the ESVS 23 guidelines, where they give it a 2A indication when the femoral approach is going to be difficult. That is a lot of arch atheroma and so on. The reason why it hasn't made it into all the guidelines is there is no randomized trial yet with this technique. Now, just this month, a trial was published in JACC Interventions, the Performance 2 trial. And this is pretty exciting results. This is traditional femoral approach angioplasty, carotid stenting, but with a big difference. One is, of course, you've got to engage the artery and you've got to cross the lesion. So that bit is still the same. But this they have a combined device now which has a stent with a balloon inside and a filter attached. So all three in one. So it's a 3-in-1 device which is 6 French, and it has, this filter has a 40 micron pore size. So it is going to trap a lot more particles than the previous filters. And remember, this is done with the regular filter on top. So this is going through the carotid artery with already a regular filter there, and now this is coming in with a second filter. And then you just have to deploy the stent and balloon it, so the manipulation is also much less. And this is this is the second study. This is performance 2. Performance 1 was the feasibility study. Now performance 2 is a pivotal trial, and pretty amazing results. The minor stroke rate 1%, that is, and then the intention to treat stroke rate is 1.3%. And that when you follow them up to 1 year, it doesn't go up very much, just 1.4 and 1.8%. So this is the lowest rates ever reported. And what is new about this system is that we have this 40 micron filter, which is going to filter out much more of the particles than before. And this is associated with the lowest ever reported rate of stroke in any type of carotid revascularization, whether it's surgical or not. So now they're moving to a comparison, the use of this in TCAR. So you can, instead of going through the femoral artery, now you go directly in and then use the system. So it may be even lower when you do it in this way. And that's going to be the next study called Performance 3 study. So that is where carotid stenting stands today. The new techniques coming in which may finally tilt the balance away from open surgery. So what about CABG and carotid disease? This is a common problem that we face in our practice. So if a patient has to go for CABG and he's got carotid disease, then what should you do about it? So if it has been symptomatic, that is TIA or stroke in the last 6 months, and it's an ipsilateral carotid stenosis 50 to 99%, then you need to do revascularization. They recommend endarterectomy today, and it can be either along with the CABG, that's synchronous, or staged. So first endarterectomy, then the surgery. In all other situations, if it's a total occlusion or the stenosis less than 50, you don't do anything for the carotids. What about asymptomatic? Here again, in all situations, you don't do anything except if it's bilateral and severe. And then again, you do either staged or synchronous endarterectomy and then the bypass surgery. So that is atherosclerotic carotid bifurcation disease. Now, the topic says carotid stenting. So we do carotid stenting in a number of other situations other than just atherosclerotic bifurcation disease. And I'll just go through a few of those conditions. One is carotid aneurysms. And I'll show you a few cases. Now this is a patient who came with neck pain for 6 months, inflammatory markers high, and he had a left carotid bifurcation aneurysm, which you see on the CT reconstruction here. This is what the angiogram looked like. It's sitting right under the bifurcation. So these can be treated with covered stents. Now I'm told that my videos won't run, so I'll just quickly skip these, and I won't be able to show you this one. Okay, that was Viabahn stent. Now this is another case, similar case with carotid aneurysm. And here it's the right common carotid artery. And this is the angiogram. And so here we deployed fluency stents, 2 overlapping fluency stents, and then a bare stent right on top to smoothen out the angulation that was at the top of the fluency. The fluency stents are rather rigid, and that is the result we got. And this is the follow-up. You can see that the stents are patent and the aneurysm is excluded. In some situations, we use balloon expandable covered stents. Here's a 47-year-old female with an aneurysm. This is a large aneurysm of the common carotid artery. The artery is quite compressed, and there's also disease in the right subclavian artery, and the vertebral artery is patent. So here we put Jomed covered stent in the common carotid artery, and then we put a bare metal stent in the subclavian artery, and we got this result. So you can see the aneurysm is excluded, the subclavian is patent, the vertebral is flowing, the carotid is flowing. And this is the follow-up 2 years later, showing patent stents and excluded aneurysms. This is 8-year follow-up of the same patient. Again, a pretty good result in all areas. Nowadays, we use the Covera stent because we don't have the wire band. And so this is a large aneurysm treated with the Covera stent. This angio is running. You can see this was a very difficult to cross aneurysm, but we managed to cross it. And we don't put stiff Amplats wires into the internal. We actually put 2 Roadrunner overnight wires, and then over that we deploy the stents. So that's a Covera stent being deployed, and then we extended it the bare metal stent to stabilize it. And this is the final result there. And this is the follow-up CT showing the patent stent and thrombosed artery. This is the 3D reconstruction of the same thing. And we can also do the same thing in pseudoaneurysms. This is a internal carotid artery pseudoaneurysm in an infant, 8-month-old infant treated with a covered stent. That's the follow-up CT. And this is another pseudoaneurysm, huge one of the common carotid artery treated with a covered stent. So this is pushing the artery forwards, and that's the Covera stent being deployed across the aneurysm. So in conclusion, you can actually treat most of these carotid aneurysms and pseudoaneurysms by covered stents, and you need femoral access long sheaths, and we don't put stiff wires up into the internal carotid. We rather use 2 Roadrunner guide wires, give dual antiplatelet therapy for 3 months, and immunosuppression is mandatory, and you need long-term surveillance. We run out of time. I can few more slides I've got. The last area I want to talk about is carotid stenting in Takayasu arthritis, which we've published our series on percutaneous interventions in 23, and we had 942 patients undergoing interventions, and in these we treated 2,450 lesions, and many of them multiple times. So we had 2.6 lesions per patient and 1.5 interventions per lesion. And the carotid was 333 patients. The lesions, 333 lesions. So if you look at the outcome in the different vessels, the best outcomes we get in the aorta and the iliac arteries. The success at follow-up is more than 90%. Then come the carotids, renals, and mesenterics, where the success at follow-up is more than 80%. And the subclavians and the coronaries do the worst. They have success rate more than 70. And on the extreme right is the average number of interventions required per lesion. So they are all around 1.4, 1.3, except the subclavian, which is 1.8. So subclavians need repeated interventions because of restenosis. So carotids, 80% of them are stented, and we usually underdilate these lesions. Initially, we just do a plain balloon and underdilate the lesion to avoid hyperperfusion, and we may stent only at the second sitting. So by the time we follow up, the success rate goes up. So there are 3 issues with carotid stenting in Takayasu arthritis. One is crossing these occlusions, because many of them are occlusions, avoiding cerebral hyperperfusion, and dealing with restenosis. So I'll show you a few examples. Here's a lady who came with bald aortic arch, all arch vessels occluded, syncope, diminished vision, stroke. So we opened the right carotid first and the left subclavian and left vertebral, and this is the follow-up. And then we opened the right subclavian and right vertebral and the left carotid, and we stented the left subclavian. So this is when we finished opening all the vessels, and this is 2-year follow-up and 4-year follow-up. Similar case, innominate left carotid occluded. So we opened the innominate and the right vertebral, and then we opened the left carotid, and then this is follow-up at 3 years and 5.5 years. So the problem of opening all these in one shot is the risk of hyperperfusion. So in this patient, we had opened the right carotid and then we opened the left carotid, and the patient developed an intracerebral hemorrhage, which proved to be fatal. So you shouldn't open all these vessels in one shot. You should do it in a graded manner. So to cross these occluded common carotids, you should see the internal on angiography through collaterals. If the internal is occluded, then it's a contraindication to recanalization. And to avoid hyperperfusion, do staged dilatation. Preferably don't stent in the first sitting, just do a balloon dilatation, stent 6 months later. And then don't do all the lesions in one shot, do them in staged manner. And restenosis basically correlates with disease activity. So you have to be aggressive with immunosuppression, and then just plain balloon dilatation repeatedly finally succeeds. And you should use long balloons to prevent melon seeding, because you can have intimal embolization and stroke if you use short balloons. So I'll stop with that. Thank you for your attention.